Welcome to ANA Investigates, a monthly podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. 15 years after the discovery of NMDA receptor encephalitis, the list of neural autoantibodies continues to grow. This month, we'll have the first of two ANA Investigates podcasts featuring updates in autoimmune encephalitis. Next month, we'll focus on therapeutics. This month, diagnostics. Our guest today is Dr. Andrew McKeon, professor of neurology and professor of laboratory medicine and pathology in the Mayo Clinic College of Medicine and Science, and a director of the Neuroimmunology Laboratory at Mayo Clinic. Welcome, Andrew. Thank you so much for joining us today on the podcast.
Oh, thanks very much for having me, Adeline.
So to get us started briefly, can you define autoimmune encephalitis?
Sure. So autoimmune encephalitis refers to a group of disorders of subacute onset with symptoms of cognitive change, memory impairment, altered mental status, mood change, seizures that evolve over a period of days to weeks, usually up to about 12 weeks. And you, broadly speaking, have two groups of patients, those with antibody-mediated encephalitis, where the antibodies reactive with a cell surface protein or receptor, such as LGI1 or NMDA receptor, and those with what's likely a T-cell mediated process rather than antibody-mediated, where the antibody is essentially a surrogate marker of the T-cell mediated process, and that would include something like MA2 encephalitis or anti-Hu encephalitis.
Great. So, many of us learned about autoimmune encephalitis in terms of classic syndromes like limbic encephalitis or opsoclonus myoclonus. But as a neurohospitalist, I've certainly had patients with atypical or subtle presentations or very indolent courses. What have we learned about the clinical spectrum of autoimmune encephalitis in the past few years?
Well, I think what we've learned is that there is a spectrum of phenotypes, and there are patients who can have quite a restricted presentation initially, that we can't rely on kind of just saying, well, an MRI was normal or an EEG was normal or the spinal fluid is normal, protein and cell count were normal. We can't rely on those things exclusively. We have to kind of build a picture using that data in conjunction with the clinical history, and then, where appropriate, to order autoantibody testing. But also we're learning a lot as we go, and even the autoantibody testing certainly isn't perfect. There are many patients that are seronegative, but ultimately would fulfill current diagnostic guidelines for autoimmune encephalitis, whether, even into the probable or definite categories where they're antibody negative.
Thanks, Andrew. So before we started recording, actually, I asked you if there were two autoantibodies where the research had been especially exciting in the past few years. And you said one of them was NMDA receptor antibody. And honestly, I was a little surprised by that. I would have guessed that we already understood NMDA receptor encephalitis pretty well. What am I missing?
Well, I think it's just that the investigators who have really taken this on have just built this out in terms of really trying to understand the pathophysiology of the disease. So from a kind of a diagnostic therapeutic standpoint, I agree that there probably hasn't been a lot of movement forward, although there are clinical trials that have started now, and I'm sure you'll talk about that more in a subsequent podcast. But as far as just kind of the molecular aspects of the disease, I think there has been some ongoing progress in that year on year. So I picked NMDA and GFAP for that reason. So for NMDA receptor encephalitis, we've learned the pathogenic mechanisms themselves. It's been demonstrated that in animal models that the antibody has pathogenic potential, resulting in cross-linking and internalizing of NMDA receptors, altering the surface dynamics of the receptor, disrupting the interactions of NMDA receptors with other molecules such as ephrin B2 receptor and dopamine D2 receptor, and that there's reversibility of those effects upon removal of the antibody. And it reflects back, I think, a lot on the kind of the clinical course, where we see that most of the time these patients don't have a lot of inflammatory change on their imaging. We don't kind of tend to see a lot of sort of gliotic change or something like that afterwards. You kind of get a very slow recovery in the clinical course over time, which I think probably parallels with the receptor getting back on the cell surface after treatment, and with those downstream networks then reconnecting and patients getting back to some semblance of normality. So we can very often see, and I'm sure you've seen in your own practices in your hospital, some of these patients are very, very sick in ICU for a very long time, but ultimately have quite astounding outcomes.
So let's also talk about GFAP astrocytopathy, which you mentioned as also being especially exciting in recent years. What have we learned recently about this condition?
Yeah, so this one has been discovered more recently, and it's different to NMDA receptor encephalitis in the sense that there's a certain amount of mystery to it. There are some aspects to it that are counterintuitive in terms of kind of the classical teaching around autoantibodies and their significance. So, for example, the target antigen is intracellular, but the clinical disease itself is actually very treatment responsive, and there are even some patients who spontaneously improve. But what kind of unifies these patients is that they have a meningoencephalitis or an encephalitis, or sometimes with myelitic features, with inflammatory changes on MRI and CSF, or both, and immunotherapy response, particularly corticosteroid response. Most are monophasic, but there are about a quarter of patients who have a chronic relapsing disease. And the pathology seems to indicate a CD8 cytotoxic T cell predominant pathology with some macrophages, microglial nodules. But in some circumstances, it's been evident that there's also some perivascular inflammation and CD20 cells positivity as well. An infectious prodrome seems to be very common, which seems to potentially imply that there may be an infectious trigger in many patients, but it's not generally identified. There have been some post-infectious HSV, VZV related cases. I think it's an exciting area. I think we're gradually learning more and more about this year on year.
Great. And, I wonder if you could comment on any really new autoantibodies, anything hot off the press that you're particularly interested in or that we're learning a lot about right at this moment.
Well, sure. I think overall, some of the antibodies are pretty common, like NMDA receptor antibody, LGI1, GFAP. There are then other ones that are coming along that are less common, but the field seems to be, from my perspective at least, seems to be moving in a direction whereby there are a lot of other targets still to discover. And in the aggregate, these are all very important for patient care. So, for example, Septin-5 antibody, which was discovered in our laboratory, we've identified 8 to 10 cases in total over several years. So it's a rare antibody, but for those patients who are affected by it, they all have the same syndrome, which is basically cerebellar ataxia with prominent eye movements. They're very often immunotherapy responsive. So for those individual patients, being diagnosed with Septin-5 autoimmunity is as important as a patient who has NMDA receptor encephalitis is diagnosed. So the challenge really is that in the laboratory, when we're looking down the microscope at indirect immunofluorescence, we're seeing a lot of different staining patterns where it's brain specific. It may be something that has been discovered in another laboratory, and we'll pretty soon find out if that's the case. But a lot of them are ones that just haven't been characterized, and they all remain to be characterized. And I feel that it's important that we try to help patients have a name for their disease, have a biomarker for future patients, be able to learn about the pathophysiology of the disease, and ultimately to help select appropriate treatments, but also give patients a sense of what their outlook is like. Whereas if a patient has an unclassified antibody or is seronegative, you don't know that. You kind of say, well, we'll treat you with steroids and we'll see what happens.
Yeah, and having cared for patients with rare autoantibodies, I couldn't agree more. It makes a huge difference for patients and their families. I'd like to talk next about how these recent discoveries tie into clinical practice. Mayo runs autoimmune encephalitis panels sent in from all over the country. We have a lot of clinicians in our audience who are probably sending these panels, and I wonder, what would you want clinicians to know as they're thinking about autoimmune encephalitis and planning to test for it?
Sure. So just a few comments on testing would be for autoimmune encephalitis, really we need both serum and spinal fluid testing ordered. You do not need to order 2 serum profiles or 2 CSF profiles. 1 of each entirely suffices. Thirdly, would be not to wait for test results before treating patients. If there is a high level of suspicion for autoimmune encephalitis in the patient and other diagnoses have been reasonably excluded, then the patient should be treated. And the other thing then is if you get a positive test result is to look at the report and the interpretation and to consider, are there any oncological implications for the test result? So in some scenarios, there will be none, but in others, there may be some recommendations in terms of searching for specific cancer types.
What have we learned about general CSF inflammatory markers like CSF white count, oligoclonal bands, IgG index? Is at least one of these markers elevated in the great majority of patients with autoimmune encephalitis? Like, in other words, can we use these tests to screen for these conditions?
Unfortunately not. Certainly there are some disorders where we see a lot of inflammation, but for instance, LGI1 encephalitis, it's very common that you may see just a slight elevation of protein or no elevation in protein. So I think that they are helpful to build a picture along with EEG, MRI, and clinical findings. But I think, in of itself, in isolation, a negative CSF doesn't rule out the diagnosis.
I wonder if you could comment on pure psychiatric syndromes like abrupt onset psychosis without other neurologic features like seizures or movement disorders. Is that a presentation that would raise your concern for antibody-mediated encephalitis or not?
Well, we've been asked to evaluate quite a few patients over time since the discovery of NMDA receptor encephalitis because of the psychiatric prodrome that generally accompanies that disorder. And most of the time, we don't find evidence of autoimmune encephalitis in those patients. So I think it's a kind of a controversial area. I think it's challenging. I think that there probably are some rare patients with pure psychiatric presentations. I have had a couple in my practice, but not a lot, say in comparison to autoimmune seizure disorders, which are relatively common in my experience as a manifestation of kind of limbic encephalitis. Pure psychiatric presentation seems to be, it's less common that we would come to the conclusion that this is sort of a form thrust of limbic encephalitis.
Well, this is such an exciting field. And as we're wrapping up the podcast today, I generally like to ask for our junior researchers, what are some of the most exciting opportunities for future research into autoimmune encephalitis?
Well, I think that there's a lot of opportunities on the clinical front. There are, as I mentioned, many disorders that still need to be characterized. There's the opportunity to get involved in clinical trials. There have been several clinical trials that have recently started in this field. Then there's at the bench level, then really trying to understand the pathogenic mechanisms of many of these diseases. I think that we kind of broadly speaking break these diseases down into kind of cell surface antibody reactive with plasma membrane protein, ion channel receptor, and so on, equals an immune therapy responsive disease versus antibody against intracellular equals T-cell mediated equals poorly treatment responsive and poor prognosis. And that's quite simplistic, I think. And I think that there's a lot more complexity to some of these diseases. And I think we'll need many bright young bench scientists to really look at this in more detail.
Well, thank you so much, Andrew, for joining us here on ANA Investigates.
Oh, thank you very much, Adeline.
That was Dr. Andrew McKeon, Professor of Neurology and Professor of Laboratory Medicine and Pathology in the Mayo Clinic College of Medicine and Science. Join us next month for a discussion of treatment of autoimmune encephalitis. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Dr. Megan Ritchie. This is your logistics coordinator, Jen Hurley. Copyright the American Neurological Association.